So, ovarian cancer, I'm going to give you an update. I'm not going to just talk about surgery, that would be boring. So I will just talk a bit in general about ovarian cancer, and then at the end we can have a chat about, things that might interest you a bit more. So, 1 in 75 women will be diagnosed with ovarian cancer. That's an important number. Why? Because if we compare it to breast cancer, this number would be 1 in 8 or 1 in 10. So ovarian cancer is much more rare compared to other diseases, like, for example, breast cancer. This means that we as scientists, as doctors, we have to deal with a much more rare clinical picture. For example, a GP will see one ovarian cancer every 5 years. That is why often, sometimes it gets misdiagnosed or not diagnosed immediately, just because it's much more rare than some other diseases that are much more common. So that's an important number, 1 in 75. Repeat things. So 1 in 75, a much more rare number than 1 in 8 or 1 in 10, like for breast cancer. So what I said before is that we as doctors, especially people who are not specialized in this type of cancer, they very often not misdiagnose, but they don't really immediately have their minds on saying, oh, the symptoms that you have might be ovarian cancer. What I said before is that a GP will see one woman with ovarian cancer in 5 years approximately. That means that, of course, when somebody comes to him or to her with the symptoms of ovarian cancer, then he or she won't immediately think of that. She will think that, oh, it's, I don't know, it's IBS, it's menopause, it's something else, yeah? It's not because they're not good enough, it's just because, or they're not, they don't have enough knowledge, just because it's a much more rare disease compared to some others. So it is the 5th leading cause of cancer in women. The median diagnosis is at around 60-65. We increasingly have more younger women who are affected by ovarian cancer, but then it's not often the most common type, which is the epithelial type, but germ cell tumors, sex cord stroma tumors, borderline tumors, these are more often in younger women. And what probably most of you know is that 70 to 80% of ovarian cancer patients will be diagnosed in an advanced disease. I always say that to my patients because I want to make clear that it's not just them being diagnosed in an advanced stage. This is how ovarian cancer behaves. This is how the majority of women come to us. So it's not the exception, but it's rather the rule that it comes in a rather advanced stage. What are the symptoms? The symptoms are very atypical. If you hear about IBS or menopause or, I don't know, gluten intolerance, these are exactly the symptoms for ovarian cancer. It's abdominal bloating, you feel a bit of digestion problems, a bit of pain, a bit of loss of appetite, very unspecific symptoms. And usually, most of the women who will have the symptoms won't have ovarian cancer. And again, going back to the GPs or to the primary practitioners, when they have somebody having this type of symptoms, it's not immediately ovarian cancer what you first think of. They think of food intolerance, menopause, and IBS. And again, this is not just because of inexperience, just because of the rarity of the disease. We know that approximately 30%, and Susie probably told you this, 30% of patients with a so-called high-grade serous ovarian cancer will have some sort of genetic mutation. Yeah, we call this the BRCA gene. The BRCA gene has had a lot of popularity and a lot of media attention since Angelina Jolie had this operation done. So when a woman comes to me in clinic and doesn't know about this gene, I always say it's the Angelina Jolie gene, and then everybody can understand what I'm talking about. However, we know that approximately 50%, so half of the women who have ovarian cancer, they will either in their tumors or in their bloods will have some sort of genetic pathway alteration that we as doctors can attack with our medicine. What we thought in the past is that ovarian cancer is one disease, it starts from the ovaries and then it just goes and affects the whole tummy. We now have realized and understood that this is probably not the case. We now think, and probably this is correct, that ovarian cancer is a fallopian tube cancer, yeah? The high-grade serous ovarian cancer. It all starts from the tubes. I try to explain it to the patients. It's like the tubes, the fimbrial end of the tube that catches the egg to, is a German word, the egg to get pregnant. So yeah, they do exactly the same with little cancer cells or little precancerous cells at the end of the tube, being distributed or disseminated or thrown into the entire tummy. This is what we think currently is how ovarian cancer starts. The most common type, which is the high-grade serous ovarian cancer. More rare types, like the clear cell or like the endometriotic ovarian cancer, they probably start from the uterus or from endometriosis. So that's why we say that ovarian cancer is not really one disease, but it's just a constellation of many clinical pictures that are just attacking the ovary, so that at the end it looks like an ovarian tumor, but it actually started somewhere else. This is perhaps a bit too much. I have here a nice picture where it explains exactly what I said to you. So this is the fimbrial end, this is the end of the tube, yeah? And these are the little cancer cells or pre-cancer cells that are sitting there for years, months. Nobody knows really how long they sit there. And then over a period of, again, months and years, they just get thrown to the entire tummy. This is how we think ovarian cancer starts in a scheme. So imagine now we want as clinicians and we want as scientists to establish a screening method, like for example the smear test. You know, we have the smear test where you go every year or every 3 years to your doctor and you get a smear from the cervix in order to see whether you have cervical cancer. We thought of trying to do the same for ovarian cancer. However, based on what I told you before, that everything starts on these little mini cells in the tubes, and the tubes are very small and hidden in our tummies, yeah? It's extremely difficult to go and see them and diagnose them in a very early stage. It's actually almost impossible. And for that reason, all studies that we have done so far, the UK was one of the leading countries doing a large study for screening in ovarian cancer, and also the PLCO study that was an American study. It hasn't shown any benefit from screening, just because we were not in a position to diagnose early the disease. Yeah? Just because these little cells that I showed you, it's impossible to be seen. You can do the best CT, the best PET CT in the world, and they won't be able to be seen. Yeah? So we actually, now we have no survival benefit of any screening in ovarian cancer. So you can't go to the doctor and say, I want every year a CA125 or every year an ultrasound. This, unfortunately, is not something that we have seen has any benefit. There have been some tries, and I'm just telling it to you because I know that many of you read and have read probably more articles than me at the end about ovarian cancer, is that we try now to catch the fluid that is being produced from the uterus, from the tubes going to the womb and then to the vagina, like for example in the form of tampons, so that we take the fluid that is being produced from the tubes, collect it into something like a tampon, and then examine it and see whether any residuals from cancer cells or from pre-cancer cells in the tubes can be seen. This is something that is very experimental, yeah, and probably, I don't know if some of you have been in any trial of that. However, there will be a trend of trying to improve that type of diagnostic methods in the future. That's perhaps too much. So, BRCA patients. BRCA patients are, as I told you, 30% of ovarian cancer will have some sort of a genetic pathway, of a genetic mutation. What I always say to somebody who has BRCA and who has ovarian cancer is that, of course, it's not a great thing for the family, for the daughters, but it's actually not a bad thing for the patient. So why? Because we know that BRCA patients, they usually respond better to platinum and usually have an overall better response to what we do for them. This doesn't mean that if you are not BRCA, you don't. Not at all. It's just a comfort if you have the BRCA gene, that usually the response to platinum down the line and down the journey is probably sometimes better. Susie discussed with you about the options in BRCA patients. That's why I don't really want to go there, and I want to discuss a bit about surgery. So the optimal treatment in patients with initially with primary ovarian cancer is a combination of surgery and chemo. It's like a team, yeah? It's like a game, it's like a team. Surgery and chemo, both. Both are important. In ovarian cancer, the last century, usually what people did is that they would open up women with ovarian cancer. They would say, oh, everything is disease and we can't do anything and we just close up. This is how we started. And then slowly we saw that the more these tumors were removed, the better these patients would do. And the better means years and years of survival benefit. So doctors who started doing these procedures, who are called debulking means removing of bulk of disease, they saw that their patients are doing better. And the more they did, the more they tried to do this debulking, the better they did. Yeah. So we started, in the last century to say that the optimal residual disease in somebody's tummy is 2 centimeters. And then we said, oh, perhaps 2 centimeters is a lot. Let's try to improve that to 1 centimeter. And then we said, let's try to put it in 0.5 centimeter. Yeah. And now we say it's 0. It's no macroscopic visible disease. So practically the aim that we as surgeons have is at the end to have a clean abdomen or a clean tummy where there is macroscopically, so what we can see with our eyes, no signs of the cancer. And these are survival curves. I really don't like to show survival curves when I talk, but this is actually a survival curve that goes up. This is a study that is from a very good friend and colleague of mine, Rob Bristow, who is a pioneer in this type of surgeries, who actually published 20, 30 years ago the fact that hospitals and centers in the US who had a higher proportion of their patients being operated well, they had a much higher survival as a hospital, as a patient's cohort, compared to hospitals that did not have such a good quality of surgery. So this survival curve is not a survival curve of patients, it's a survival curve of patients' cohorts in hospitals. So you see that practically as a team, as a whole patients' cohort in one hospital, these patients will do better if this hospital is more specialized in what they do. And that is why in the UK was one of the first countries in the world to have dedicated cancer centers that treat women, not just with ovarian cancer, but with any cancer. There are still countries in Europe, and I have been trained in Germany, I'm half German, that anybody, the obstetrician that delivers your baby, can also treat your ovarian cancer, which is, of course, the wrong thing to do. Yeah? So you're very lucky as British patients to be in the UK and to be treated in the NHS in large cancer centers. Yeah? That is something that is for you normal, but it's not the case for many, many people in Europe. Okay? So why do we operate? Why do we think that surgery is enough? What I always try to explain is that ovarian cancer is not just one tumor in the ovary like a ball. This is how most patients think of it. It's like one ball in their tummies and that's that. Ovarian cancer is like a rush, like a little rush that goes to the surface of the skin of the tummy. Yeah? And this rush very often is very small, so we can't see it in the imaging. That's why CT is not always really giving us any help. And we have seen that by removing many of these little dots, and the more you remove, the more sensitive we do these women for chemotherapy. So when the chemotherapy has only to attack smaller tumors or microscopically not visible tumors, the response is higher than if you have really big bulks of the disease in your tummy. Yeah, that is why we think that surgery has this survival benefit. So by trying to reduce the tumor, we make the patient the chemotherapy more effective, in simple words. Of course, many people say, these are big surgeries, so what about morbidity? And I just had an interview and they asked me, what are the complications of surgery? There is nothing in medicine that we can provide as doctors that does not have side effects, nothing. Even the paracetamol or even the aspirin you take has side effects. And the same is with surgery. So it's always about balancing the morbidity or the complications that you get from any procedure, not just surgery, also chemotherapy, also PARP inhibitors, anything, with the alternative, which is not to have treatment. not to have treatment, it's not that it doesn't have any side effects. It, of course, has, and very often it's much more than doing something about it. I'm Greek also. That's Scylla and Charybdis, yeah? That's from the ancient, that's where Odysseus wanted to go through this path, and either he would get hit by one or he would get eaten by the other. So it's choosing between two evils. There is no discussion that it's a difficult journey. It is a journey and it's a difficult one. And there are very difficult decisions always that have to be made. But it's about fighting at the end. It's not about choosing complications, about whether you choose you want to fight or not. I think it's the most important. So there is no question that we as surgeons and as oncologists have evolved through time. This is a picture from Wertheim, Ernst Wertheim. Ernst Wertheim, he's the one who developed the radical hysterectomy for cervical cancer. So this was, women in, that was in 1898 in Graz in Austria, where there was no smear test, there was nothing, yeah. So women, they would have these big cervical tumors and they would bleed and they would die. So Ernst Wertheim thought of trying to operate that. So he would cut like that, like a cesarean section, and he would try to take out these big tumors. And some of the patients did well, but 74% of the women would die during surgery. Yeah, this is how we started as gyne-oncologists. Okay, and of course we have evolved from that. This is how breast cancer. This is how we used to operate breast cancer. Yeah, because we thought the more we take out, the better it is. Of course, these are pictures of the past and morbidity and complications of the past. We are not there anymore. We now, by all the medical advances that we have, not just surgical advances, but also better screening methods, better adjuvant options, so what you can give, like Susie said, in terms of systemic treatment. We now can tailor our surgery and can minimize our surgery so that we do only what is necessary with much lower morbidity than we used to do in the past. Yeah, there is no question about that, the fact that we evolve as surgeons and we evolve as oncologists. And we now are not just doing clinical trials to see how long women will live, yeah, it's also how well these women will live. The Lion study is one of the biggest studies in surgery for ovarian cancer about the value of taking out lymph nodes, yes or no. And like in all modern studies now, we have a very big aspect of quality of life. So that it is important for us to see not how long our patients live, but also how their quality of life is. And of course, this is a very typical curve, and that's why I have it for you. Immediately after the treatment, of course, the quality of life gets less. Yeah, it's like, I had a cesarean section 3 months ago. Yeah, I couldn't walk for a week. I was in the sofa. I had a terrible quality of life. Okay, it's not about that. It's about the long-term quality of life. And the long-term quality of life, and we mean 6 months and more, it's actually so that it is better than before, as you see, because the disease has been treated. Usually this is how the quality of life curves look like. Victoria told me that also many of you are interested in the indications of surgery at relapse. So the majority of ovarian cancer patients will have ovarian cancer again at some point after initial diagnosis. So the question is whether we should operate or not. Susie discussed with you already about the fact that we have now much more options in terms of chemotherapy and PARPs and whatever when the cancer comes back again. But we also now have a bit more knowledge about the value of surgery when the cancer comes back. Desktop, and this is a name that perhaps you have heard, it's a German study. German started, but many centers took part from many countries, including the UK. Where we tried to evaluate the value of surgery when the cancer comes back. And it was actually a very ambitious study. It was a study where we took, I don't remember how many it was, around 600 patients. Half of them had surgery and then chemotherapy when the cancer came back again. And the other half just had chemotherapy and no surgery at that point. And what we saw is that patients who had surgery at relapse, they had a longer break from their disease compared to those who did not have surgery. This does not apply to all women. And why? Because it's not all women that we can get tumor-free. This applies only to those where we as surgeons can get out all the disease when it comes back. So for example, if the disease comes back with, I don't know, in areas where we are not able to access them, then surgery is not the right thing. And for that reason, it's very, very important that we as teams and clinicians know how to identify the right woman and the right patient to operate when the cancer comes back. We have tried within the German AGO, which is one of the biggest societies in the world for gynecology, to have a signature of what is an indication for surgery when we operate. And what we said is that it's the so-called good performance status. Good performance status means that the woman is able to cope with a big surgery. Yeah. The second is not too much ascites, so not too much water in the patient's tummy. And the third is that to have had a good surgery in the beginning when the cancer came initially. Yeah. This does not mean, and I know that some of you will ask me about all these criteria, this does not mean that somebody who had suboptimal treatment, so not a great treatment, for which reason, yeah, in the beginning is not qualifying for surgery when the cancer comes back again. That is absolutely not the case, but it's always an individual journey together with your doctors where the surgery would be the right thing for you when the cancer comes back. How old was Nikki? 30 when we operated. So she had a very radical surgery. It's important for me to show these pictures because very often people say radical surgery is bad because it makes your quality of life terrible and you have stomatas and you can't do anything after that. That is, of course, if you have a problem, sometimes the case, but it's not the case in the majority of the patients. Nikki went on her horse 2 months after the surgery. So I don't think I could do so amazing. This is a picture. I don't know if no, I don't see any. This is Alison, one of my patients, and this is another one of my patients. Again, happy that we show this picture. This is a patient. It's a picture of women with BRCA, with the BRCA gene. Many of them had breast and ovarian cancer, and they look amazingly glamorous. Yeah, even though they have a very difficult journey behind them and ahead of them. And we continue and continue and continue how at the end it's your power that is going to defeat the disease with a bit of our help. Thank you. So I think we have time for questions. Yeah.